Welcome to WE'RE on ECMO, an educational series for the extracorporeal community. Here with us today is Callie Dayton, a critical care nurse practitioner and critical care outcomes consultant. You may have heard her as the host of Walking Home from the ICU and Walking You Through the ICU podcast. She is dedicated to creating awake and walking ICUs by ensuring ICU sedation and mobility practices are meeting current research, and she works with ICU teams internationally to transform patient outcomes through early mobility and management of delirium in the ICU. Callie, thanks for joining us today.
Thanks for having me, Neil. This is exciting.
I appreciate you being here, and I'm just going to hop right into it. I've got a good question for you, and I'm really excited to hear your answer and share it with others. What do you tell an ECMO specialist who thinks less sedation and more mobilization will make their job harder?
I totally understand this question because I, as a nurse, saw very intimately what it was like to turn down sedation after it'd been on for a while. And patients come out agitated, thrashing, delirious, and that can be extremely stressful. So when we talk about avoiding sedation, there's obviously a lot of pushback because they're like, I'm not going to do that. My whole shift is try to ride this bucking rodeo. That's not what we're wanting to accomplish here, though sometimes it may require that. And what we're hoping to accomplish is to prevent delirium, to shorten the duration, to lessen the severity of delirium. But we have to understand and appreciate that sedation is the main modifiable risk factor for delirium. Sedation increases the chances of developing delirium by 8 times. And then we need to understand what it's like for patients when they are sedated. I think we assume that patients are sleeping, that the less they move, the less their eyes are open, the less aware they are of the environment, the more comfortable they are, the more humane it is. So when we turn down sedation and suddenly we unmask the delirium and it results in this emergence agitation, it's really stressful for clinicians because now we're seeing the suffering that they're experiencing under sedation. And so it's perceived as so much easier to just turn sedation back on or to never mess with it. But we do need to zoom out. I know we're going to talk about what's easiest for our perfusionists, but we need to zoom out and look at the big picture and ask ourselves, why are we here? Why did we get into medicine? Why do we want to work in the ICU? And I think most, if not all, clinicians would say because they want to save lives and alleviate human suffering. And I would invite you to check out episode 118 of my podcast. It's with an ECMO unit that decreased mortality by 30% just by starting an early mobility program during the height of the Delta wave of COVID. They looked around and saw that 75% of their patients were dying. And they said, what do we have to lose? Here's what the evidence says saves lives. Let's just try it. And 30% improvement in mortality immediately happened. So we need to ask ourselves, why am I here? Right. Is it worth it? From my personal experience, I worked in an Awake and Walking ICU. It was a medical surgical ICU. We weren't doing ECMO, but we allowed patients to wake up right after intubation and mobilize shortly after. And that was so much easier than what I experienced as a travel nurse years later when I was having to do awakening trials and take off sedation after it had already been running for a while. Because patients coming out of sedation, like induction medications for intubation, come out like it's a colonoscopy. And you just reorient them. Now, when it comes to ECMO patients, I don't know that you're always going to have that opportunity. Right. I hope that the rest of the ICU community gets to the point where we ask every time a patient's intubated or every time we go to face sedation, that we ask, is there an indication for sedation? Because if there is not an indication for sedation, there's no intracranial hypertension, if patients can oxygenate with movement, if there aren't seizures, things like that, then we should be letting them wake up right after intubation so that we don't have this emergence agitation, this crazy delirium. We're not having to worry about them pulling out their lines and tubes. They actually know what's going on and they protect their own devices. So that is what I envision for most of our ICUs and even ECMO units. But even if that's not an opportunity. When patients develop delirium, I guess there is a question of, is this going to make my job harder? And maybe in that moment it will. Maybe you will be a little bit busier, having to keep an extra eye out to make sure that they don't wiggle out of the restraints. Maybe you will have to spend more time using human tactics. You will have to talk to your patients.
Right.
That's just the way it is. If you want them to survive and have a chance to survive and thrive after the ICU, if you want to avoid a sedation-induced brain injury, long-term physical impairments, if you actually want your patients to survive and go back to their lives, you might have to give them a pen and paper. You might have to answer some questions. You might have to maybe hold their hand. You might have to talk to family more and teach family how to interact with them more. You may have to push a cart with a machine down the hallway. But what you're going to get in return is nothing in comparison. You will have, or the sacrifice is nothing in comparison to what you will receive. You will have job fulfillment. You'll have human contact, human interaction. You'll actually get to see your patients for the people that they are, not just decomposing bodies in the bed. You'll have actual connection. And not that you're looking for it, but patients will thank you. And you'll have the satisfaction of knowing that you're making a difference, that you're helping them through one of the most difficult experiences of their lives, and you're saving them from so much damage and harm that could have happened had they been sedated and immobilized. So if you're really in it for the right reasons, it's worth it. And it won't be as hard as you think it will be. If we really work together to make sure that we minimize sedation right away and we prevent delirium, then you're much more likely to have patients chilling on their cell phones, texting you messages as far as what they want to say, and they're protecting their own devices and tubes.
That's awesome. Yeah, I think I hear, the passion in your voice as you talk about it, but then I also know that there's the research that backs that up. And so I think that's great feedback for anybody who might be taking care of critically ill patients, especially.
Here's some of my favorite, if you're talking about the research, here's some of my favorite like highlights from the research, things that shocked me after 6-7 years of working in the ICU. I never knew certain things. I didn't know that delirium is really acute brain failure. It's an organ failure that's associated with worse outcomes than other organ failures. So we're really focused on the heart, the lungs, the kidneys, right? But we neglect the brain. And sedation disrupts the brain activity so much that it prevents real restorative sleep. And that's one of the ways it causes delirium.
Yeah.
So when we say, no, it's inhumane to have them be awake. No, it's inhumane to have them sleep deprived. And when they're that sleep deprived in the delirium, they develop an alternative reality that's usually much more graphic and traumatizing than anything the ICU could do to them. They think they're being sexually assaulted. They think their kids are kidnapped. The worst things are happening. I don't think any of us want to do that to our patients.
Right.
And that trauma is just as real as if they had physically lived those experiences, and they carry that with them for the rest of their lives. And this can be life altering and even life ending to have that much PTSD. You think about like your worst nightmare that you've ever had, you wake up in a jolt, and maybe throughout the day or in the next few days, you're kind of like trying to remind yourself that wasn't real, but you carry that with you. Okay. This is what patients can experience for days to weeks when they're sedated, and they can't just talk themselves out of it. And then they have cognitive impairment. So it's hard for them to really cope with that trauma. So they lose their livelihoods, they lose their relationships, they lose the life that they knew before. So that's proven in the research. Delirium doubles the risk of dying in the hospital. So we're doing a lot of work on the side. Running the ECMO machine is a lot of work, but what are we doing it for? If we're giving lethal medications that are doubling their risk of dying, is it worth it? When we look at 2-year survival rates for ICU survivors, just in general, but especially I'm sure for ECMO patients, those that did not have any ICU cord weakness or diaphragm dysfunction, 76% survived 2 years after discharge. If they developed ICU cord weakness and diaphragm dysfunction, which usually happen hand in hand when patients are atrophying with sedation, only 36% survive thereabouts. So this is about a 40% difference in survival of 2 years. So you're determining not just if they survive the hospital stay, but if
Mhm.
they survive 2 years later after discharge.
Yeah.
So this is all evidence-based. The best way to let them survive and thrive is to wake them up. Now, is it worth it to a perfusionist? I guess I can't answer that for you.
Yeah. Yeah. I mean, I think the key is if our only metric is survival, then maybe not. But if we have other metrics, like what does it mean for them to thrive once they're home, and I think then yeah, we got to start exploring that question more often and finding out ways to improve patient care and outcomes in the long term, not just
Yeah.
immediate.
Well, even immediately, right? I mean,
Mhm.
this ECMO unit, they published
Yeah.
that their study looking at dropping mortality by 30%.
Mhm.
And if it was your loved one in that ECMO unit
Mhm.
and there was a chance to improve their mortality by 30%, wouldn't you go for it?
Yeah.
That's
Yeah.
huge. If that was a medication that could
Mm.
improve mortality by 30%, we would be 100% compliant.
Yep. Yep. That's an excellent point. Well, I really appreciate you sharing your expertise. I know the more folks that learn about this and embrace these sorts of ideas, undoubtedly it's going to enhance patient care and outcomes. And so I really appreciate what you're doing. I know you have a lot out there to offer people. You mentioned your one episode, but there's lots more people can learn, as well as their peers throughout the hospital. So where can people find you and your content?
So my content is organized on my website, the site,
Yeah.
DaytonICUconsulting.com. If you go to the resources tab and then under the transcriptions, the clinician podcast, it goes numerically, but if you scroll down, it's organized by topics.
Okay.
So there is a whole section dedicated to ECMO.
Okay.
You'll hear from ECMO survivors, a current ECMO patient. I interviewed an ECMO patient that had a passing mirror valve, and she was basically biking almost during the interview.
Hmm.
Um, and you can also listen to survivors of sedation and immobility. And I think that's really important. If we want to change our practices, we need to understand the patient perspective. So I'd invite you to listen to survivors and to clinicians and everyone throughout those ECMO and sedation survivors episodes. So Dayton ICU Consulting, go to the resources tab, and you'll find a clinician podcast and all the transcripts.
That's awesome. Well, thanks for sharing that, and hopefully people will go and find that, and I think the survivor things are key. We recently had a survivor speak at one of our ECMO for rehab professionals, the PT/OT course, and she got to share her story about what it was like to get up and move, and the difficulties that she faced while she was on ECMO. And that really helped enlighten those folks. And I think that their practice probably is forever changed by that 30 minutes, which is really cool. So thanks again for sharing. If you're watching today and you have questions and you would like to have an experienced professional answer that question, make sure that you email me, Neil, NEIL, at ECMOadvantage.com. Thanks again. See you next time.